Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. In this short video and lecture, I'd like to show you the importance of pseudocapsule and how to preserve it during the surgical treatment of myomata. Actually, fibroid pseudocapsule is a small thing, but it has big meaning. And pseudocapsule is a real name because it is false capsule. It is not related to the fibroid. It comes from the myometrium. So it is a myometrial tissue surrounding the fibroid. And it has been found to contain a lot of neuropeptides and neurotransmitters and is enriched by blood vessels, and it may have a role for the supply of the myoma with blood, and also may have endocrine and other neurovascular functions. And if you look to this example of an orange, when you cut the capsule around the orange, if you leave we leave this white area surrounding the fruit itself, and this represents the pseudocapsule. We don't eat this white part because it's not related to the fruit. So during myomectomy, we don't have to remove the pseudocapsule because it is not related to the myoma. And it is responsible for many functions of the myometrium, like peristalsis and, of course, healing. So it is a specialized myometrium, is responsible for nourishment the fibroid with blood, and may have effect on the fibroid by its hormonal function, like effect on estrogen and progesterone and some interleukins. But actually it is a neurovascular structure plus fibrous band, and this fibroelastic tissue makes an envelope around the fibroid and acts as a mechanical barrier, and also decreases the myometrial damage during myomectomy and favors correct myometrial healing. And by this way, restoration of the physiologic myometrial functions and decreased risk of myometrial fibrosis and subsequently the uterine rupture. And it has been found that the thicker the pseudocapsule, the less liability to rupture, and the thicker myometrial pseudocapsule is may have an effect on fertility and increasing fertility if it is 2 millimeter or more. This may affect fertility. This supports that it is not just a fibromuscular area or a fibroelastic area. It is a functioning layer around the fibroid, and if it is damaged, this will lead to fibrosis due to hypoxia, ischemia, and necrosis, and decreased neuropeptides, neurotransmitters, and this will lead to poor physiologic healing, decreased myometrial neurotransmission, and decreased myometrial impulse and contractility. And by this way, there is impaired uterine muscle functions during pregnancy and delivery. How to see the pseudocapsule? Simply during transvaginal sonography, you can see an echogenic line encircling the myoma, characterized by a clear wall of several millimeters and enhanced distal echoes. In Doppler, there is a characteristic ring of fire surrounding the myoma. In the 3D, you can see it around the myoma, and there are some calculations using the Foucault method for estimation of its thickness, and actually in this study has been mentioned to be 1 to 3 millimeters. During MRI, you can see it as hypointense layer surrounding the fibroid, and hypointensity comes because it is myometrium, it is muscle tissue. If it contains fluid or lymph, like in cases of venous or lymphatic obstruction, the appearance will be hyper intense, and this is a real problem for differentiating it from the adenomyoma or even sarcoma, because this layer is not present in such cases. But we have to put in mind that pseudocapsule is the most important landmark during myomectomy, regardless the method of myomectomy are using. And here in this picture, you can see the myoma, and this is the pseudocapsule surrounding the myoma. You have to leave it. You don't have to cut it. You don't have to cut in the myometrium and leave and take this 2 to 3 millimeters with you during myomectomy. This is a great problem during myomectomy. So if you are doing open myomectomy, hysteroscopic or laparoscopic myomectomy, you have to identify it and to see it and to preserve it, not to include it during the myomectomy. And here in this short video of laparoscopic myomectomy, you can see that after opening the myoma, open hysterotomy, after opening the uterus, you can see the surgeon is trying to separate the pseudocapsule from the myoma and to leave it. If you take it with the myoma, this is a great mistake. By this way, you are distorting the uterus. You are delaying healing of the uterus. This is separation of the pseudocapsule to be included in the myometrium, not in the myoma itself. And by this way, if you cut and separate the pseudocapsule, you are preserving healing of the uterus, proper healing of the uterus, and continue the neurotransmitter function and endocrine function of this important layer, in addition to some interleukins. So here is the myoma is removed, separate away from the pseudocapsule. And this in case of hysteroscopic myomectomy, when you start to cut the base of the myoma, a big myoma, here is the pseudocapsule. You are trying to preserve it, just keep it and push it towards the uterus, and don't take it with the myomectomy. And more details on this technique are demonstrated by our team in this previous study of modified hysteroscopic myomectomy of large submucous myoma. So you have to preserve this layer of pseudocapsule, whether hysteroscopic, laparoscopic, or open surgery. In conclusion, we have to know that the knowledge of its anatomic, biologic, and functional properties can improve the results of laparoscopic, robotic, laparotomic, hysteroscopic, or V-nodes myomectomy, to reduce bleeding, to increase safety, to perform more effective and functioning surgery. And by this way, we can restore the normal biology of the myometrium and keep proper healing of the uterus and avoid the subsequent rupture uterus later on. Thank you.